Morning, guys. Dr. Gillard once again. Here we are. Hope everybody's doing well today. It's Thursday. It is, what is the date today? I know it's the spring. It is April 9th, 2020, spring 2020. And this is our last lecture on cardiovascular and pulmonary pathology for this week. So here we go. So this is where we left off. We're going to talk about blood flow now. We're talking about epithelial cells, how magical they are. They do all sorts of things. They have all sorts of receptors communicating with the lumen of the blood vessel. They release all sorts of things. So let's continue that discussion. And these epithelial cells, of course, they are on blood vessels, right? They are in the lumen of blood vessels. They make the lumen of blood vessels. So what else can they do? They can regulate the flow of blood by controlling the diameter of the lumen. How in the world can they control the diameter of the lumen? And you guys know what I mean, right? The diameter of the lumen. There's a blood vessel. That's the lumen. Right? There's the whole blood vessel. This is the lumen. So they can make this small or they can make that big. How in the world do they do that? Well, they can do that by controlling the Tunica Media, which we haven't got to, but we'll talk about that today. Remember, that's the muscular inner layer of a blood vessel. It's the middle tunic. So they can contract that or they can relax that. How in the world do they do that? Does anybody know before I turn the page here? Well, nitric oxide is kind of the big star, right? So we need to talk about nitric oxide. It is the most important endothelial-derived vasodilator that's released, and it's abbreviated NO, nitric oxide. Don't confuse it. I've thrown this on the test to see if I can trick people. Don't confuse nitric oxide with nitrous oxide, right? That's drag racing fuel. Nitrous oxide, or it's kind of the laughing gas they can use at the dentist's office. That's N2O. So watch out. Ick means ick. I hate this stuff. It must be stuff I have to memorize. You don't have to memorize nitrous oxide. And don't be hilarious, O-U-S, hilarious. Don't be hilarious. Don't choose this answer, right? So don't mess those two up. So NO diffuses from the tunica intima into the tunica media and binds, causing relaxation of the muscles of the tunica media, and therefore the vessel diameter opens and you get increased blood flow. So nitric oxide is constitutively released, meaning it's continually released from healthy epithelial cells. And so it always keeps the blood vessels in a slight state of vasodilation. It opposes, and it's more complicated than this, but this is the way you can look at it for now. It opposes the blood vessel's natural tendency to constrict. So we have two forces, nitric oxide trying to open the blood vessel and relax it, and another force that's constantly flowing out of your medulla, and that's sympathetic output. It's a little tiger. I'm not sure if we talked about the sympathetic tiger, but we will, I think, today. But that's always trying to constrict. Sympathetics plug into the tunica adventitia, but they indirectly cause contraction of the smooth muscle. And those two forces give us a nice kind of a medium opening of mainly the arterioles. Oh, I did something fancy, didn't I? What did I do here? Okay. What normally stimulates the release of nitrous oxide? No, not nitrous. I'm trying to be hilarious. Nitric oxide. Too much shear force. So shear is something, a force that's scraping on something, right? You guys know that. If this is the surface, let's say this is a blood vessel here, and here's a red blood cell, maybe in an area that's not laminar flow, but it's scraping as it moves along the blood vessel wall. And it could be platelets, and it could be just blood fluid. This dragging or scraping across here, that creates a shear force, right? And then you have all the endothelial cells would be here. Right? And it's dragging across there. That creates a shear force. Okay, so that's not particularly good. Okay, then what increases the shear stress? Well, anything that increases the velocity of blood, the faster the elements of blood move, the more drag and banging and scraping they'll produce on the endothelial surface, the apex of the endothelial cells. And so hypertension, any type, primary or secondary hypertension, that'll do the trick. How does nitric oxide, what's its relation to shear force? Well, increased shear force or shear stress or banging on the blood vessel wall. It'll stimulate the epithelial cells to release more nitric oxide. And that'll increase the relaxation of the tunica media. That'll increase the diameter of the lumen. That decreases the velocity of the blood. It's like putting your finger over the garden hose. If you want the hose to spray out slower, just take your finger off the garden. It's like opening up the lumen. And that decreases blood velocity. It decreases blood pressure. So that's an important relationship. I think you could already probably answer a question like that. Fight hypertension. So nitric oxide is one of the mechanisms used to combat hypertension. So if your blood pressure goes up and the shear force goes up, you release more nitric oxide, and that lowers it back down. Well, great. So why do we have hypertension then? Right? Wouldn't some people hypertensive, wouldn't it just release more nitric oxide and your pressure would be normal? No, because it's not a permanent mechanism. Unfortunately, it's only a short-term mechanism. And then what are some things that can damage these endothelial cells? Some other things. I kind of mixed up the slide, looks like. So chronic hypertension we talked about, but smoking can also irritate the blood vessel wall and cause the release of nitric oxide. Atherosclerosis. But the bottom line is here, it's a short-term fix. The mechanism can't go on very long, but yeah, it won't go on forever is the bottom line. What effect will this have? And the sources is Guyton here. Guyton's a board book, right? Well, the hypertension will ramp up then, and this mechanism won't control hypertension. We have the atrioneuritic system, though, right? Our natriuretic system. That controls this, but we'll get to that in endocrinology. We have controls for hypertension. All right, so here's the character. My generation knows this little guy. Here's the first YouTube star right here. Google Mr. Bill, and look at some of the stunts that he's been through over the years. This is the first YouTube star. Severely abused back in the day. I think he's been shot into space on a rocket. He's been thrown through a wood chipper. You name it. He's been to the dentist office. They've done everything with this guy. This is the first YouTube star here. And we can actually use Mr. Bill. Dr. Gillard, how in the world can you use Mr. Bill to talk about nitric oxide? Well, there are two medications that are actually really popular, and we can use Mr. Bill right here. So if you take a cross-sectional view of the penis, hey, look, it looks like Mr. Bill, doesn't it? So remember our anatomy here. We have corpora cavernosa, two corpora cavernosa. Now these are filled with blood vessels, right? So this can fill with blood and make an erection. We have corpora spongiosum right here as well. Does the same thing, but not nearly. I mean, the erection makers are these corpora cavernosa right here. All right, so what's the cause of an erection? So here we go with this stuff. I don't know if you've had this before, but so penis gets stimulated, and that causes the release of nitric oxide in the blood vessel cells in the corpora cavernosa by two mechanisms. Not only do the endothelial cells themselves release nitric oxide, but there's some cavernous nerves that also live in there that, remember the dorsal nerve of the penis, they branch out into cavernous nerves and a bunch more, and they can actually release nitric oxide. So now we got nitric oxide floating around in the corpora cavernosa. So this is a gas, so it can diffuse into the smooth muscle that is in the blood vessels in that region. That's in that stuff that's in the corpus cavernosa. And it can cause it to relax, and as the blood vessels relax, blood comes pouring in, and more blood fluid spills out into the corpora cavernosa, and that causes the penis to become erect. So that's how a penis gets erect. Never knew we're doing a little sex ed today, did you? So, but now let's get a little bit deeper. So once the nitric oxide gets into the tunica muscle cell, nitric oxide binds with an important enzyme called guanylyl cyclase. Guanylyl cyclase, right? So this binding that's nitric oxide's job is done at that point, because the binding to this enzyme stimulates it to make a new product, and it's called cyclic GMP, or CGMP for short, from GTP. Right? So now we have cyclic GMP floating around in the corpora cavernosa. What does that do? Well, that binds to the smooth muscle cells, and it stimulates them to release calcium. It kicks all the calcium ion out of the muscle cells of the tunica media. And we know from physiology that calcium is very important to have around if you want to make a muscle contraction. So therefore, smooth muscle cells, they relax. And if smooth muscle cells relax, what happens to the diameter of all those corpora cavernosa blood vessels? They pop wide open. So more blood is dumped into the region, and then you get an erection. So let's get it off my slides here. Cyclic GMP is also thought to induce. Here's another mechanism. There's another enzyme that it stimulates. Cyclic GMP specific protein kinase is also stimulated by cyclic GMP. Not just the dumping of the calcium ion, but this enzyme is turned on, and this causes a dissociation of actin and myosin. Mechanisms not completely understood. So there's kind of two functions of cyclic GMP. All right, but bottom line, as I said, so the vasodilation of all the blood vessels in the corpora cavernosa lets the blood flow like crazy in there, and some of it spills into the interstitium of the corpora cavernosa, and that causes the erection. Okay, we're good with that? Now, here's a new star of the show. How do we turn off the erection? Erection is not supposed to last forever. So there is another one called cyclic GMP specific phosphodiesterine, or we're just going to call it PDE5 for short, because that's too long of a word. PDE5. So normally, cyclic GMP eventually runs into and binds with this enzyme floating around, PDE5. PDE5 grabs cyclic GMP and turns it off. Okay, so that results in, if it deactivates cyclic GMP, without cyclic GMP, nothing binds to the smooth muscles, and the sodium comes pouring back in. Or not the sodium, the calcium starts moving back in. Okay, and that causes, with calcium around the muscles of the tunica media, or the cells of the tunica media can contract, and that constricts the blood vessels of the corpora cavernosa, and you lose your erection. Right? How come? Because calcium is back within the smooth muscle, and that causes constriction of muscle, right? Causes contraction of the actin and myosin. Simple as that. So bottom line is PD5 turns off cyclic GMP, and the erection stops. Okay, now the problem with old people. So older people, I don't like to say old. I mean this is old, but I think old now is like 80. But anyway, older people, they don't produce nitric. You start to lose your production of nitric oxide when you start getting into the later 40s. And if you lose your production of nitric oxide, that whole chain is broken, right? So you lose your ability to have an erection, a super common problem. Decreased nitric oxide equals decreased guanylyl cyclase stimulation equals decreased cyclic GMP. Without cyclic GMP, you can't do all those things, and you can't vasodilate the blood vessels inside the tunica or inside corpus cavernosum. So what's an old man to do with this problem, especially if he's got a younger wife? The little blue pill, right? So here's one medication that can help out old people. So they take the little blue pill and things are good. This, of course, is Viagra or sildenafil. I can never say that word. Sildenafil citrate. Just call it Viagra. So now we need to know the mechanism. Now, a lot of stars should be floating around here. I always ask a question on this stuff. So Viagra, how does it work? Well, it diffuses into the area that we're talking about, into the corpus cavernosa tunica media, and it finds that Turner offer, that cyclic GMP Turner offer. Who is that? PDE5. It finds it, and it binds to it, and it blocks its ability to do its job. And so without PDE5 around, because old guys can still make a little cyclic GMP, it starts to build up, and the erection works because you have lots of cyclic GMP around. You don't have as much as a younger guy, but that's okay because you have way less PDE5, activated PDE5 around. And so therefore, you can get an erection. The old guys can get an erection. So Viagra directly inhibits the breakdown of cyclic GMP. How come? Because it turns off the breaker downer of cyclic GMP, which is PDE5. Pretty good with that. Therefore, there's everything I said. There's more cyclic GMP around, so it stimulates the vasodilation of the corpus cavernosa blood vessels. More blood fluid drains into the corpus cavernosa, and you have an erection. What happens if younger people who don't have erection problems, what if they take Viagra? You remember, they don't even have those commercials anymore for Viagra, but they used to say, warning, go to the emergency room if you've had an erection lasting longer than 5 hours. They literally can have an erection that doesn't turn off. And they do have to go to the hospital. And people have damaged their penis. Young guys have damaged their penis by taking too much Viagra. And they can't get the blood out of their penis, and the tissue becomes ischemic, and some have lost their penis because of this. So not a good idea for younger guys to mess with this stuff. Here's just an overview of where we've been, everything I talked about. And it's not just cyclic GMP. There's a little PKG is involved, but we'll just keep it to cyclic GMP is good enough for us. But for those of you who have to know everything, here's the exact mechanism. No stars here, so deep enough. So what else can nitric oxide be used for? What else can we do? Well, what about this guy? He's having pain. He's having angina, chest pain. That's a pre-heart attack. So is there a use for nitric oxide? And there actually is. There's another really common product, the nitrates. And so nitrostat is a super common one. So nitrates are given to patients to combat chest pain from clogged up coronary arteries. Maybe their coronary arteries are 90% occluded, and maybe they took some Viagra like they're not supposed to, right? And now they have ischemia of their heart and they're getting chest pain. Or maybe they walked up the stairs that they like to do and they're not supposed to. Or maybe they went out and played tennis. Now they got chest pain, and it's precursor to a heart attack. So they can pop some nitrates, and that pain is released because the coronary arteries are open back up. So let's take a look at that. So narrowing of the arteries produce myocardial ischemia, as we said. Heart muscle starts starving for oxygen and starts to become damaged. It'll let you know there are pain sensors in there, or they're autonomic in origin. but both the vagus nerve and sympathetics, there is an afferent division of both of those, and pain can be carried down both of those, and that's what happens. So the mechanism of nitroglycerins, or nitrates, which is nitroglycerin, still not completely understood, but nitrates cause the release of nitric oxide. We do know that for sure. And that's not just in the heart, that's everywhere in the body. So nitrates stimulate the epithelial cells to release nitric oxide. We don't know if it's an irritant or how it works, but they dump out nitric oxide. And you can imagine the story from there. Just like before, the nitric oxide stimulates guanylyl cyclase to produce cyclic GMP, and then this same ordeal. Cyclic GMP diffuses in the tunica media, binds to the smooth muscle relax because it dumps calcium out into the interstitium. And yeah, the coronary artery opens up and blood flow is restored and the pain stops. Can you see why cardiac patients should be very careful about taking Viagra plus nitrates? Think about that for a second while I take some water here. They used to think it could cause a heart attack. Can this cause a heart attack? No, it can't cause a heart attack. What could cause a heart attack is if you take Viagra and you have severe coronary artery stenosis and it's not enough to open the arteries and your physical effort overpowers your heart, you could die of a heart attack. So here's a hint on the question. Both of these are vasodilators. You can't have two vasodilators going at the same time, right? And they go all over the body. So the Viagra also affects the heart as the bottom line. And so the danger of taking Viagra and nitroglycerin or nitrostat or nitrates, the danger of taking those two together is it causes too much vasodilation everywhere over your total body, and your blood pressure drops like a stone, and people have passed out, become syncopatic, passed out, hit their head, and died because of this. It does not cause a heart attack. That's a myth that was going around for a long time. It does not cause a heart attack. It causes hypovolemia. Some patients have went into hypovolemic shock because they've taken too much. Went to a party and took a fistful of Viagra and went into hypovolemic shock. Some have died from that. So if you're on nitrates, you do not take Viagra. Okay. Again, it's not true that this combination increases the risk for myocardial infarction like you used to think. Right? It's hypotension that is the problem. All right, let's look at, we looked at nitric oxide. Let's look at what about a natural vasoconstrictor of the tunica, of the vessel lumen. So endothelin is the star here. So very powerful vasoconstrictor. So powerful it can completely shut off a small artery. So it's very powerful. Endothelin is not secreted all the time. Right, so it completely shuts off a small vessel. We'll talk later about the connection between endothelin. There's a lot of research on endothelin, some gene mutations. You're not supposed to secrete this stuff, but in some people they found that they are secreting endothelin when they're not supposed to because of mutated endothelial cells, especially in people who have pulmonary hypertension, which is a nemesis. We'll talk a lot about that. It leads to right-sided heart failure. We'll talk about that when the time comes. What are some other things, endothelial cells? We've been talking a lot about what these things can do. Well, there's immune response that they're involved with as well. They can secrete adhesion molecules. I won't get into those, but they help lymphocytes. If there's an inflammation, a virus invasion somewhere, they secrete molecules that help the lymphocytes stick to the area. They also secrete these pro-inflammatory cytokines, which can be great, but they can be a lot of trouble. There's a lot of research and a lot of drugs attacked at knocking out pro-inflammatory cytokines, especially the king of all pro-inflammatory cytokines, tumor necrosis factor alpha. Type that in your PubMed and type sciatica, radicular pain. There's a lot of information on people with chronic sciatica, how they overproduce this pro-inflammatory molecule. So that's another thing they do. They can secrete these pro-inflammatory cytokines, maybe too much sometimes, but sometimes you might need it if you're fighting for your life. Other functions, they can secrete growth factors to repair damaged vessels and to make scar tissue. Then they endothelial cells secrete another really important molecule. You may have heard of this one, von Willebrand factor. So we need to stop here because this is kind of my realm, and we need to talk about von Willebrand factor. So inside the epithelial cells, there's these fascicles floating around. Like there's one there, and those are called Weibel-Palade bodies. So they're found everywhere. The only place they're not found, and we're inside the Tunica Media now, we're inside the endothelial cell itself. So all endothelial cells in the bodies have these little Weibel-Palade bodies, except lymph vessels. They're the only ones that don't have lymph vessels. And no, they're not these Weibels, but that's the way I remember it, right? I don't know if you guys remember. You're probably too young to remember Weibels, but those were really popular back in the day. So that's kind of sounds the same, right? Weibel-Palade bodies. So let's talk about them. So who cares about Weibel-Palade bodies? Well, they're the ones who synthesize von Willebrand factor. Not to be confused with, remember the joints of von Luschka, the Luschka joints? Another German guy they're named after, the guy who discovered them. But yeah, they store von Willebrand factor, and when you're bleeding too much and it's time to shut off the bleeding, they secrete von Willebrand factor, and it's a blood clotting factor. So, or you could also say, AKA, make sure you know, add to your vocabulary list, hemostatic factor. It plays a super important role in blood clotting. I'm not going to say blood clotting. I'm going to say it plays a super important role in hemostasis, controlling the bleed. Hemostasis is the process of stopping hemorrhage. Okay. What does it do in general? Well, it stops bleeding. It's like flypaper being cast out into the lumen, and its job is to catch platelets, and platelets can stick and start piling up here. So that's what it does. Great for stopping bleeding. It is considered, here's another vocabulary word, it is considered a prothrombogenic molecule. Sometimes they'll kick the pro off and just say a thrombogenic molecule. You need to know that word. What does that mean? That means the molecule that can stop bleeding. But if you release too much of it, what could happen? It could actually cause clotting, a process called thrombosis, which is evil, especially if it happens in arteries. Shouldn't really use the term clotting, even though everybody does. Clotting, technically, you don't clot blood inside the lumen of a blood vessel. You thrombose the blood. Clotting occurs if you have a bleeding blood vessel and you have a clot, that you can clot blood outside the blood vessel or clot blood inside the tunica media in a tear, like a dissecting aneurysm. I think I said that before. What else does von Willebrand factor do? It chaperones and protects coagulation factor 8. So factor 8, it's its buddy. It's its protector. Factor 8 sucks at clotting blood if von Willebrand factor isn't there. It's like Batman and Robin. Robin's not very effective if Batman's not there. But together, the two are very good at clotting blood, and that's the same here. So if you have dysfunctional, if you have a mutation in the gene that makes von Willebrand factor, and von Willebrand factor is kind of crippled, your factor 8 won't do very well either. So those two they go hand in hand. So that brings us to, oh boy, I'd sure like this one, don't I? Von Willebrand disease. Super common board one here, Canadian and U.S. boards. probably medical boards. I mean, everybody, you got to know von Willebrand disease. So it's a problem. All I'll say is it is a mutation of the gene, and chromosome 12 is the one that makes von Willebrand factor. And it's a mutation of that gene, and you get a crippled von Willebrand factor, and it doesn't work very good. It's mutated. Sometimes it works a little, sometimes it doesn't work at all. And therefore, if you get a cut or girls get their period, any bleeding event, you have a lot of trouble stopping bleeding. And so, yeah, that's the deal. You have dysfunctional hemostasis, right? And if von Willebrand factor is messed up, factor 8 is messed up because they work Batman and Robin, right? So now factor 8 does, so it's kind of a double whammy. So it's really difficult to clot your blood. And why do I like von Willebrand disease so much? It is the most common inherited bleeding disorder, more common than all of the hemophilias. And by the way, this is not a hemophilia. Hemophilias, we won't go into them. You'll get those somewhere else. But yeah, it is not one of the hemophilias. Okay, von Willebrand disease is not a hemophilia. They're a different animal. So there are 4 subtypes of von Willebrand factor, but we're not going to get into all those. That's too deep for boards, too deep for us. But they all do the same thing. You can't stop bleeding because of this. Typically, it does not cause internal bleeding like the hemophilias do. It doesn't usually cause bleeding into joints, like swelling of the knee from bleeding in the joint. Hemophilias can do that. So, again, it's not one of the hemophilias. Hemophilias are more rare. If you're going to have a bleeding disease, it'll be most likely be von Willebrand disease that you have. These patients can be asymptomatic and never know that they have it because von Willebrand mutation is not too bad. Maybe they bleed a little longer, but they've never noticed it. They get nosebleeds more often than most people do, but it doesn't interfere with the span of life or anything like that. People who are symptomatic, bleeding all the time, they basically have anemia symptoms. They're dizzy, they don't have low energy, they don't feel good, get infections. They can be severely ill, can be really disabling. And in fact, some of them have to get regular transfusions, and they have to actually inject new von Willebrand factor and new factor 8 into that transfused blood. And so it can really be disabling in some people. Here's a little chart, hemophilia versus von Willebrand disease. There's 2 types. There's the hemophilia A and B that are around. Again, they're pretty, you can see that 21 out of 100,000 males. 30 of these are caused by spontaneous mutations from exposure to maybe too many CT scans or maybe an infection or whatever. So you're not born with the mutation. But the majority of them are, it's an X-linked condition. Then von Willebrand, that's again the most common hereditary coagulated disorder. Affects 1% of the population. I mean, this one is no joke. Marfan's syndrome is about 0.01% of the population. I don't like to go much lower than Marfan's. Anything rarer than that I usually don't talk too much about. But this one affects 1% of the population. But about Marfan's syndrome is symptomatic. So 0.01% is symptomatic. Okay, von Willebrand factor affects usually the skin more and the mucous membranes more than hemophilias do. Here's the targets. These people have problems with nosebleeds all the time. Mouth, they'll eat something like corn chips or something sharp, and we've all kind of bit weird on a corn chip, and it's like, kind of stabbed yourself with a corn chip, but you don't start bleeding. These people will start bleeding from that. And then they can have intestinal bleeds, and they can have hematochezia, depending on where the blood coming out with the poop. Or they can have melena, melanic stools, dark, tarry blood coming out with the poop. They get their periods and they bleed like crazy from after their periods. They have intercourse and they bleed after that, so it can be really disabling. Hemophiliacs, usually the bleeding is more internal, which can be a problem as well. I mean, these aren't a good diagnosis either, but they tend to bleed into joints and muscles. So I think that's all the deeper we need to go about that. Common symptoms of von Willebrand disease: frequent bleeds. Targets are again, the mucosal membrane, the skin. Nosebleeds are really common in these people. Everything I just said, pretty much. And from all the bleeding, I mean, these people become anemic. They have the symptoms of anemia. They have no energy. They bruise. They bump their elbow on the door or something, and they have a huge bruise after that. All right. So now let's get back to the histology. Water break here. Sorry, there's no way to cut that out. I'm scared that Camtasia will crash, and I don't want to lose these things. Okay, Tunica Media. Let's talk about that. We talked about it a little bit, but let's get into the histology. It's really important, too. I think I've talked a little already about the elastic recoil of the aorta. We'll look at that a little bit more. It's probably a Dr. Doe slide here. Tunica, or there's the lumen of the blood vessel. There's the endothelial layer, and there's Tunica Media. You can see how way bigger than the endothelial layer, right? And adventitia. We might get to that. We'll see how we're doing. See if I remember how. I kind of watch my clock here. I'm used to having breaks. We usually take a good 10-15 minute break every 45 minutes or so. So I'm going straight through to save time, and you guys, of course, will be able to take breaks whenever you want, right? We'll just stop the video. Tunica Media. Okay, so we just looked at it. It's the middle layer, artery or vein. Veins have these as well. Lymph vessels have these. It's usually the thickest layer of the vessel. It has an interesting design histologically. It's like a sandwich, and it has multiple layers of smooth muscle and then elastic laminae muscle, kind of a springy, stretchy layer, and then another layer of muscle. So it's a really weird design. We'll look at it in a sec. The elastic laminae is not the same as the internal and external elastic laminae. The Swiss cheese layers are different. Remember, we think those are in arteries, they're not in veins, to give them a little extra strength. We're not really sure the function of them. But the elastic laminae is different. These things are stretchy and springy. So how is it designed? You can consider Tunica Media a smooth muscle elastic laminae sandwich. So sheets of elastic laminae are held together by collagen and elastic fibers. Well, let's take a look. It's a really nice drawing of these things. And if you scrape all this stuff off, I mean, it kind of does look like an internal, external elastic laminae. It looks like that Swiss cheese effect. But at each layer, they've added more components. So if you just add the elastic fibers, and this is in the Tunica Media of the blood vessel wall, you can see it has elastic fibers going from one Swiss cheese layer to the other Swiss cheese layer, right? So this thing's going to be stretchy. On top of that, you add collagen. So here's the collagen and the elastic fiber added in. And then there's some other elements as well we don't need to talk about. But here's what the real one, all three of these would look like this. The artist just kind of made it easy for us so we can understand this. And so these are the elastic laminae. There's actually 4 of them in this artery. And the interesting thing is, as you get older, you actually can increase the number of collagen in between these sheets, and you can even increase the number of sheets somehow. You can grow new sheets in here. So maybe someone, if this is 30, someone 70, maybe they'd have 6 sheets of elastic laminae in here and way more collagen. Therefore, it would be more stiff than a younger person. It wouldn't recoil very good. It wouldn't conform to that big blast of blood coming out of the aorta. Right? And of course, there's many of these. Here's the real tunica intima. I mean, there's I don't know. I don't know what the count is, but it's a lot more than 4. There's probably like 20, 30 of them in there. Okay, so that's the design. So what does the Tunica Media do? We talked about the stretching. You guys know what that is? That's an accordion. It's kind of like the Tunica Media is in a way. So during systole, it stretches out because of the big blast that's coming out, right? We can get our little drawing tools out here. So here's the left ventricle, we'll say. Again, this is why I don't draw. But blood just came out, so you get a stretching, especially of the ascending aorta, to compensate for that blood coming out. And then during diastole, it shrinks back down. Right? Kind of simple as that. Why does it shrink down during diastole? Because the Tunica Media collapses. It was stretched out here during systole. In fact, we'll talk about this little region. There's actually a region that gets more stretched out. You can see in cadaver hearts from where the blast of blood hits it. That can actually interfere with the superior vena cava in some people, especially people with Marfan's, Louis Dietz, and the connective tissue things. But that's important. But when it contracts back in, that's important as well. Because let's go back to, I wonder if we have a green color. Oh, we do. So we'll make Mr. Spock blood. We'll make green blood. Or is it Romulan blood? Who has green blood? I can't remember which one. But when it contracts, it forces more blood, because diastole is occurring, we're taking a little nap. So it forces blood and kind of helps sustain the pressure. It doesn't do it perfectly. We do have a little drop in pressure, but it keeps the pressure up. If you've ever cut a vein, you can see you still bleed pretty steadily from a vein. You don't squirt blood out like you do when you cut an artery. But the important part, it backwashes some blood this way. Remember, we got these semilunar valves, and it shuts these semilunar valves, this backwash. A tiny bit of it actually gets back into the ventricle, but not very much, because these valves shut. So that's really important. Older people don't have that. Older people have a very stiff and non-stretchy aorta. So therefore, when systole occurs, the pressure is much higher, especially systolic pressure. And they do tend to get, their systolic reading goes higher and higher as you age because of the stiffness of the aorta. So everything I just said, remember, recoil is critical, keeps the blood flowing, closes the semilunar valves. Everything I just said is in stone here. Right, and there's a little better demonstration, which I did. Much better depiction of the valves. They're like little drag racing parachutes. They catch drag racing parachutes catch the wind. These catch the blood backwashing during diastole, and it prevents blood from dumping back in here. Pretty simple concept, I think. Now, everything I kind of talked about, aging and hypertension, but here it is in stone. Remember, I don't test if I don't. That stuff I talk about that's not on slides, it won't be tested. I won't write a test question unless it comes from these slides. So as people get old, the number of elastic laminase increase. So the Swiss cheese increases. And especially if the patient battles hypertension, because that puts undue force and stress and irritates the vessel, and it lays down more Swiss cheese. The collagen fibers also thicken and stiffen. Well, so what? Well, they get hypertension. So the thicker collagen and extra laminae thicken up the tunica media, and if it gets thicker, a tunica media that's thick decreases the lumen size, right? Do I need to draw this thing? You guys probably understand this, but go blue. So here's a regular artery. We'll forget the endothelium. Let's say here's a normal tunica media. And here's an old person. Why is the lumen so small? Because they have a big, thicker Tunica Media with more of those internal elastic laminae, and it narrows. What's that going to do to blood pressure? Is the pressure going to be higher in that pipe or higher in this pipe? It's just like putting your finger over the garden hose, right? It's going to be higher in this pipe. Right? Yeah, simple concept. So narrow lumen's going to equal hypertension. Heart has to, is the body tissue going to suffer? The flow through there is not going to be the greatest either. But the body's tissue is not going to suffer because the heart is going to pump harder to overcome those narrow pipes. So now your heart is working a lot harder than it has to, but your tissue's still going to be happy. It's still going to get the proper amount of blood at the expense of your heart. And that's what happens to people with hypertension who don't take their medication and don't get it under control. Right? We always try to, can we treat hypertension? Well, there's actually research on that. We've tried, and chiropractic does not work for treating hypertension, obviously. But remember, we're primary healthcare providers. Can we talk to the patient about eating correctly? We absolutely can. And cutting salt out of their diet, we can consult them, and we can maybe have them avoid taking hypertension medication. Maybe they're a salt eater. Maybe that's the problem. The medical doctor's not going to ask them about their diet and salt. They're just going to prescribe them meds and go on to the next patient. But we can certainly help. You always want to try nutrition and eating correctly before going on any type of medication. All right. So, I wonder if you can hear my stomach growl. I should have eaten, I guess. My mic is pretty sensitive. Let's see. So, yeah. So, we've talked about all this stuff already. The extra collagen stiffens the artery. It also loses its ability to recoil. So what? Who cares about that? Well, what about the semilunar valves if it loses its ability to recoil? Who's going to close the semilunar valves? And that's a problem with older people too, right? The semilunar valves, the aortic and the pulmonic valves, they don't close very good, and you start getting a regurgitation. So that's not a good thing because it overfills the left ventricle, and if you overfill the left ventricle, it ejects more powerfully, and it's overworking the heart. So that's another mechanism that leads to heart failure as people get older. Okay, pretty simple concept. So recoil normally dampens and absorbs the blast of blood coming out. It also raises systolic pressure. We already talked about that as well. The vessels lose compliance. They lose their stretchiness. So kind of a double whammy, people getting old. Everything I said, the stiff aorta tends, with lost compliance, narrows, it worsens with the passage of time. So these people typically get a steady increase in systolic pressure. Diastolic pressure may not be that affected, as we'll see. It can even decrease, actually, in older people, but not systolic pressure. So these people have systolic dominant hypertension. All right, so let's switch gears. Talk about the carotid sinus story a little bit here. All right, remember this. Back in the day, common carotid artery bifurcates into an internal carotid and an external carotid. Remember that. We won't go through all these. Getting gross 1 flashbacks, superior thyroid. We won't go through those. And this is not correct. This is not drawn correctly. The carotid sinus is actually at the root of the internal carotid artery. This is where the carotid sinus is, right here. It's not down here, so the author needs to guide. It's common in making anatomy mistakes. But that's where it's supposed to be, so that's off. But the principle is still good. So we have a carotid sinus, and within it we have a chemoreceptor, which we don't want to talk too much about. It's also connected to the same nerve. But we have baroreceptors in here, right? The carotid sinus, the tunica media, is kind of hollowed out, and it's filled with baroreceptors, similar to the the kidney, juxtaglomerular cells. So it's constantly sensing the pressure, and I mean really sensing the blood pressure. It communicates with something I call the tiger cage, which is the vasomotor center that's in the medulla. How does it communicate? And the action potentials are constantly flowing. This thing is always on. And it communicates via the glossopharyngeal nerve, specifically a branch of it called the nerve of Herring. So the board question could say nerve of Herring, or could be not so deep and say just glossopharyngeal nerve. But that is the nerve that is monitoring the carotid sinus and monitoring the pressure. You popped out of bed this morning, you woke up, this mechanism corrected your hypotension to your brain. As you stood up, your blood, it's delayed, right? So you have blood loss to the brain, and this thing shuts off when blood pressure drops. And it allows the tiger to come out of the cage when it shuts off. There's a steady flow of action potentials. These are inhibitory, right? These are inhibitory on the tiger cage, and they keep the tiger cage gate shut as long as the signal is flowing. But if you stand up, if blood pressure drops, it decreases the flow of action potential, and that cage door is spring-loaded, and the cage door can pop open, and the tiger is loose. The sympathetic tiger, of course, can cause Tunica Media spasm really quickly, and can shoot your blood pressure up to correct from that drop in blood pressure. I just got way ahead of my slides. But normally, it's an inhibitory signal sent to the vasomotor center, as I said. It keeps the tiger cage door closed when it's flowing. If you have hypertension, you have strong action potentials flowing through here. It really tries to keep the tiger cage gate. You let the tiger cage gate open and you already have hypertension, you're going to have malignant hypertension. So important concept, and let's keep working on that story. So the carotid sinus, via action potentials, the information about the blood pressure travels down the nerve of Herring, branch of cranial nerve 9, jumps over onto the main cranial nerve 9, glossopharyngeal nerve, and it reaches the vasomotor center. Okay, so nerve of Herring, or Herring's nerve, innervates the carotid sinus. Carotid body as well is innervated by the same nerve. So the signal is inhibitory. That's a common question that I always switch that around. I say the signal coming out of going down the nerve of Herring is stimulatory. It's not. It doesn't stimulate anything. It's inhibitory. It has an inhibitory effect on the spring-loaded tiger cage gate. So the inhibitory signal, how does it work? Increased blood pressure, increased signal, increased vasomotor center inhibition, tiger cage door is closed, and that decreases the sympathetic flow because the tiger is the sympathetic flow, decreases sympathetic flow, and decreases blood pressure. That's kind of the little mechanism set off by hypertension. Okay, so hypertension is what stimulates that thing, or to create more inhibitory signals. So let's look at my little cartoons now. So here's the vasomotor center. This is sympathetic outflow. This cage, I couldn't find that, was cracked a little. Remember that there's always a little outflow. So this cage door is open a little bit. Here's the spring-loaded stick that holds the cage door shut. Maybe this patient has hypertension and the nerve of Herring and cranial nerve 9 is firing like crazy. So maybe this is a situation where the patient has hypertension. It's trying to completely shut. And in reality, even people with hypertension have a little bit of sympathetic outflow all the time, but not much. So that's the point. So normally the tiger cage door is mostly closed. A little bit of it comes out, but that's the scenario. So this is the nerve of Herring and cranial nerve 9. And these are the action potentials holding that tiger cage gate shut. Okay, and that's just when the tiger does get out, that's just some of the pathways that it uses, and you guys, I won't go over these. You know these from Dr. Doe, I'm sure. Now, what happens when you have a drop in blood pressure? You just got up really fast from laying down in bed, and your blood pressure dropped. Or what if you have heart failure and your pressure drops like that? Doesn't matter. If you have a drop of pressure and the nerve of hearing senses that, carotid sinus senses that, it decreases the rate of firing down the nerve of hearing. So you don't have many action potentials. Maybe there'll be no action potentials if it's a severe drop in blood pressure. So that takes away the spring-loaded gate stick. So without that stick, right, if you have hypotension, all these action potentials stop, and the stick relaxes. Maybe it falls down. And the tiger gauge, the gate swings open, and out comes the tiger. Right? So door of sympathetic swings open widely, so that the sympathetic flow is out. So the nerve of hearing action potential in a case of dropped blood pressure, the action potential output is low. In fact, it's directly proportional to the level of blood pressure. I like these directly proportional questions. So if you decrease blood pressure, you decrease the flow of action potentials down the nerve of hearing. If you increase the flow of blood pressure, you increase the inhibitory flow of action potentials down the nerve of hearing. So make sure, quite a few stars here, make sure you, can't say for sure, who knows what I'll put on the test, but I do like that question, that one, when I go through the slides, that sticks in my mind. So back to our story. So here's another spring-loaded gate. You can see the gate here. So this patient has hypotension, so the stick has fallen, and the tiger is loose, and the tiger's actually coming to the rescue, because we know once the tiger comes out of the cage, it's going to cause spasm of the tunica media in the arterioles and venules, and that's going to shoot up blood pressure. Right? If you narrow the lumen of the blood vessel, that increases blood pressure. That's not all it does. It also stimulates the SA node to fire up, and the heart starts beating faster. It decreases the slowdown portion of the AV node. Remember, the AV node's job, it's called decremental conduction. The AV node's job is to grab the signal coming through the atria, stop it, slow it way down, to give atrial systole a chance to fill the ventricles. We'll talk about that more when the time comes. R2A system is also turned on. R2A system is too slow, though. It's not going to immediately correct. It takes a while for that system to ramp up. But nevertheless, it can still, there are sympathetic nerves plugged directly into the juxtaglomerular cells. I mean directly. And it has them secrete renin directly without any pressure. That's why one of the mechanisms they think people with increased sympathetic tone have hypertension. They may have increased levels of renin because of that mechanism. So the sympathetic system, this is what's going to save your life if you're bleeding, though. All right, the R2A system is not fast enough to do that. All right, everybody good with that? Sympathetic affects the R2A system, just what I said. The barrage of sympathetic outflow directly stimulates the juxtaglomerular cells. It causes them to directly release renin into the bloodstream. Here's a little cartoon of it even. Sympathetic nerve endings plugging right into the juxtaglomerular cells, and they're releasing renin. So, they do that. Remember, juxtaglomerular apparatus is triggered by decreased renal artery pressure. So because this is CVPP, this is not part of GIGU class, so we kind of overlapped. I didn't used to teach these classes at the same time, but it's a good little review. So remember, decreased pressure in the afferent arterioles of the kidney also directly causes the release of renin. The decreased pressure and flow through the proximal tubule, right? If you have decreased pressure, the filtrate flow is going to be slow. And the potato pickers are going to have more time to pick out the sodium ions. So the filtrate is going to be decreased with regard to sodium ion. All right, and that freaks out. Remember the macula densa freaking out. And then macula densa, therefore, indirectly stimulates the release of renin. It elbows its buddy. It's connected to many of the macula densa cells are connected to the juxtaglomerular cells, and it stimulates, tells them, hey, release more renin. So what about orthostatic hypotension? Okay, we should talk about that. I should probably take, my voice has got a long way to go today, right? Sympathetic output, extremely important for maintaining blood pressure. When the human rises, we've kind of been talking about this. If you get up fast from the bed, or if old people just get up, period, you get a big drop in blood pressure because of gravity, especially if your heart isn't as powerful as it used to. And that can make you dizzy and pass out. You could hit your head. Old people have to get up really slow and be careful of orthostatic hypotension. So normally this drop is detected by the carotid sinus, and as the mechanism we just discussed, carotid sinus goes, oh my gosh, the blood pressure has dropped. I'm shutting off the flow, the inhibitory flow to the tiger cage. We need the tiger loose immediately. So it shuts off the flow, and the tiger is loose. And that increases the sympathetic outflow, and it does its job. It causes vasoconstriction of the arterioles and venules, stimulates the heart, and it really quickly, within a minute or so usually, it increases blood pressure, and you may be dizzy. And some of you with hypotension probably have to be careful. Or everybody, I think, has gotten up really fast and went, whoa, I feel a little dizzy, but it's corrected quickly. So normally within seconds, within a minute for sure, the blood pressure should be normalized. Not always the case, though. So orthostatic hypotension is a problem where some people get up and they get that dizziness feeling, and it can last for hours and hours. And it can really be a big problem. It can be severely disabling because that mechanism is messed up. So when that happens, when grandma gets up and she's dizzy for the morning, and takes until around lunchtime she's feeling better, that's called orthostatic hypotension. That needs to be investigated. Okay, so how do you make the diagnosis? One of these days I'm going to put this in lab instead of taking blood pressure, which you guys already know how to do, kind of know how to do. But anyway, it's pretty simple. So the patient lies down for 5 minutes in a quiet room. You come in, put a blood pressure cuff on, and take the blood pressure. Okay, write down the blood pressure. Now you tell the patient, okay, stand up quickly. Stand up, quick, stand up. You wait for 3 minutes and you take the blood pressure again. Well, they might be a little dizzy, so be careful they don't fall. But within 20, 30 seconds, the pressure should be back to normal, and they say, oh, I feel good now, no problem. But you wait. The gold standard all throughout the world is 3 minutes. Get your watch, time it 3 minutes. And then you take the blood pressure again. And here's to make the diagnosis of orthostatic hypotension, there has to be a decrease by greater than 20 millimeters in systole and or 10 millimeters in diastole. All you have to have is one of these numbers low, and that makes the diagnosis of hypotension. It's not uncommon to see 30, 40 millimeters in systole after 3 minutes. And you could keep on measuring. You could measure in 5 minutes, and you could see how long it takes to come back. But that's beyond our scope. We just want to make the diagnosis. And so it's a real easy way to make the diagnosis of orthostatic hypotension. Who cares about it? Well, there's some pretty sinister causes. One of the most common is early Parkinson's disease. That's the way Parkinson's could present. It damages the autonomic nervous system. It damages the nerve of hearing. So the nerve of hearing doesn't work very good anymore, and the tiger cage just stays at the same level, and it doesn't respond to hypotension like it's supposed to. All right? There's another thing called multi-system atrophy is another one. MSA is another more rare condition, but that can do it as well. Parkinson's is the big one, though. Everybody's heard of that one. Anything that damages nerves, sympathetic nerves, nerve of Hering can do that. Or not only nerve of Hering, but the sympathetic nerves, the ANS in general. Diabetic can do that for sure. So people with diabetes tend to have this problem. Same mechanism. People who maybe their nerves are fine, and this is probably a really common cause too, they just have hypotension all the time. All right, but people who have hypotension, they have an exaggerated response to this. So maybe they have cardiomyopathy, the heart is failing. Or maybe the heart is okay, but they have aortic stenosis and they can't get good blood pumping out of the heart because of the aortic valve is constrictive. Or maybe they have palpitations so bad, they have PVC so bad that they don't have a good ejection fraction. So these can all cause orthostatic hypotension. Right? Some other fixable cause is chronic dehydration, so you could fix that. Medications are notorious. Diuretics, vasodilators can do this. People who drink excessive alcohol can have problems with this. Adrenal insufficiency patients who have decreased aldosterone, that just leads back to hypotension. Pernicious anemia patients, right? Pernicious anemia, vitamin B12 deficiency, that damages the nerves. The myelin around the nerves is damaged, so that system doesn't work very good. All right, what are the symptoms? Pretty easy slide. The symptoms are pre-syncopatic symptoms. What's syncope? It's dizziness, like lightheaded, to the point you pass out. Or syncope is feigning. Pre-syncope is close to fainting. You look a little bluish, a little greenish looking. You're lightheaded and dizzy. We've all seen people like that. Maybe you've even had that before. Maybe you've had a vasovagal event where you get pre-syncopatic. Weakness, fatigue. Some patients faint completely. Boom, hit the ground. Difficult to treat. People with orthopedic, what do you do if their sympathetic nerves are damaged? If it's medication, you can correct that, or if it's dehydration, you correct that. What if they have Parkinson's and their sympathetics are damaged? Well, one idea sounds like something House would do, but you add salt to the diet. You give them a high salt diet, which will raise blood pressure. All right. Let's see. Do we want to go any farther than that? That's usually about, I can feel it in the air. That's probably about, you know what? Let's just get through this. Why not? And then we'll call it just a few more slides. Tunica adventitia. Let's talk about that just so we can finish this. That, of course, is the outer layer of a blood vessel. It is made up of connective tissue in there, mostly collagen, some elastic fiber. In arteries, remember, it has that extra Swiss cheese layer, the external elastic laminae. Remember, veins, again, do not have an internal or elastic laminae. We think because they don't need it, because they don't have that high of pressure. Its outer surface, there's a connective tissue that's around blood vessels. We didn't see that in lab. Mama Z dissected that away. But sometimes that loose connective tissue is the only thing saving you from dying from an aneurysm. You rip right through all three tunics and you're bleeding. That connective tissue can be fairly strong and help you get to the hospital. It'll be very painful, of course, when you rip through a blood vessel. Its cell population is mainly fibroblasts, and it's relatively thin compared to the in most arterial systems. Large arteries and veins, it contains, this is an important concept, it contains its own blood vessels. What in the world? Why would it need its own blood vessels? We got blood flowing down in the lumen. Well, how's the blood going to diffuse through the tunica intima and tunica media to feed the tunica adventitia? That ain't going to happen in big vessels. So it needs its own arterial system, arteries and veins. So, of course, you guys usually know this by now. That's called the vasovassorum. So, blood vessel within blood vessel. So, that's awesome, right? The inner half of the tunica media and the tunica intima, They don't need any blood vessels. They can diffuse their oxygen and nutrients right through the tunica intima. But the outer half needs its own system, so you get blood vessels within a blood vessel. Also the source of a dissecting aneurysm, which we'll talk about when the time comes. So typically it's a vasovassorum externa that you have, where the supplying little arterial here, or small vein, small artery comes from the outside, but not always. Some people have vasovassorum interna that actually come from the lumen and go all the way through. Some people have mixed system. Now this, by the way, is called a venous vasovassorum. A vasovassorum means arterial. Venous vasovassorum means vein. Got to have veins, right? Pipes go in, you have to have pipes going out. Why do we need this thing? Well, I explained this already. Because they need servicing. The inner half doesn't need servicing. The outer half needs servicing. I already explained this slide. The three different types, did I say this? I don't know if I said this. But vasovassorum externa, that's the one that comes from the outside. Vasovassorum interna comes from the inside. Sometimes you can have a combination. So here's a mixed vasovassorum, where this person had a pipe going from the inside and one going from the outside, and this artery was very happy, right? It's super well fed. And there's the vasovassorum interna, vasovassorum externa. Okay, so who cares about this dumb stuff? Well, we do, because we're dissecting aneurysms can occur. In fact, vertebral artery aneurysm can occur, particularly like to occur from ruptured vasovassorum more than other regions of the body. So these little blood vessels, they can pop and they can leak blood and they can form a clot inside the tunica media, or they could rupture the tunica media and cause a through and through type injury, which we'll look at when the time comes. But yeah, this is a form of dissecting aneurysms, especially in the vertebral artery. And we'll talk about these further on down the road, but I'll give you a sneak peek. Here's a vertebral artery in some dude, and he developed he had an interna vasovassorum, and for whatever reason, maybe he has Marfan syndrome, he had a weak spot in the vasovassorum, and one day he was lifting weights or working out and had super high pressure, and he ripped it. And it wasn't strong enough to rip completely out, but the tunica media is not designed for longitudinal forces. So it's really easy to rip the tunica, the middle of the tunica media, straight down. And that's exactly what happens. That's a dissecting aneurysm. And these may or may not, the bigger ones, usually there's enough pressure to rip back in. That's called a double barrel, is the most common type. So they eventually kind of had double flow. The trouble with a double barrel is if the noodle's up here, the brain is up here. I guess I should have changed the arrows the other way. But while you have blood clots in here, right? You got hard clots of blood. What happens when you rip back into the main lumen? What happens to all those hard clots of blood? It's like a shotgun, right? Shotgun pellets. You're shooting all those clots into the blood, and they're going to get stuck in the cerebellum or wherever they happen to land by chance, and the patient has a stroke. So super common problem. And it can happen after a chiropractic adjustment. Chiropractic's not the only one that can do it. Electricians, anything that extends, laterally bends, and rotates the cervical spine can irritate these vertebral arteries. And if the gun is loaded with clots, it could rip through, and those are called precipitating events, and we'll talk about that when the time comes. So let's not forget that the tunica adventitia also has some sympathetic fiber in there, right? And that's called the nervi vascularis. And yeah, it's got sympathetics mainly in there. They're postganglionic sympathetic fibers, and they release, for our purposes, norepinephrine. And that can diffuse super quickly into the tunica media, and that's how sympathetics cause tunica media to contract. It's kind of indirect, isn't it? They release norepinephrine, and that diffuses into the tunica media, lickety split, and you got yourself a vasoconstriction, and that's going to boost blood pressure up. All right, now I'll say a prayer that Camtasia does not lose what I've just done. So we'll see you later on today for another lecture. Fingers crossed, everybody.